disease has been treated effectively by ballonangioplasty and stenting, but no rating for this recommendation. And finally, we have the European Society of Vascular Surgery. They said in patient with clinical relevant chronic iliofemoral obstruction or in patient with symptomatic non-thrombotic iliac vein lesion, pectoralis transluminal angioplasty and stent recommended should be considered and give it grade 2AB. So who then is candidate in both Europe and the American guidance? They said CEIP class 3 through 6 for chronic venous disease. Patients should be stented, but the clinical guideline did not specifically address the patient with CEIP class 1 or 2. But it is acceptable by most society guidelines that patient with lesion must be symptomatic to treat it with the venous stenting. So we cannot just do venous stenting just because we see compression or Maytner syndrome on CAT scan. Patient has to be symptomatic or he has an ulceration to be treated. And it has to be, as I said, CEIP class 3 through 6. What patient should be excluded? The contraindication for venous stenting in general include uncontractable coagulopathy, local systemic infection, patient has a lesion that prevents complete inflation of balloon or proper placement of the stent, and finally, patient whom anticoagulation or antiplatelet therapy is contraindicated. So, which lesion should be stenting? Expert opinion, most guidelines agree that a lesion should be both symptomatic and more than 50% diameter reduction or venogram or IVUS, or more than 50% area reduction on IVUS to be considered for treatment with venous stenting. The expert, but the only problem is the expert disagree about the minimum degree of stenosis in which lesion should be stented, varying between 30 to 70%, and how to measure the vein stenosis, like example, using the area or diameter against the ideal size or contralateral vein size, as well as the native size of the deep venous system. So they did not agree on this, how we measure the venous stenosis and the minimum degree of stenosis which need to be stented. But everyone agreed that if you have more than 50% stenosis, patient symptomatic, they need to be stented. So let's come to a question. So I'd like you guys to answer this question. Which of the following statement related to the stenting of venous lesion is true? Choose all that apply. Clinical guidance are silent regarding patient with CEIP class 3 to 4. This is wrong. For 3 to 6, we know that we have good recommendation. It's acceptable by most society guidelines that patient with lesion must be symptomatic to be treated with venous stenting. This is correct. Expert opinion typically agree about the minimum degree of stenosis at which lesion should be stented. No, so they did not agree on the minimum. So this is wrong. The last one, careful selection of both patient and lesion may be more important than technical skill required to place a stent. This is correct. So the correct answer will be the second and the fourth one. The second question, venous stent provide a solution to the patient with iliofemoral outflow obstruction who may not be getting treatment by tortuous venous system. It has to be durable, non-susceptible for fracture, even with a hip flexion, especially with a young patient. So we're looking for long-term durability. And finally, you have to have an accurate deployment, like an easy and precise and predictable stent placement. Let's go through each one in details. First, the sizing, stent sizing. When we say the size of stent 10 by 40, what does that mean? 10 usually is the diameter and the 40 is the length. The usual minimum size sheath size for venous stent using 0.035 guide wire, usually between 7 to 10 French. That's not the big deal in the venous system. Even 10 French with a compression, you can stop the bleed, you don't need any pain. Usually you need to use 12 millimeter diameter or 125 millimeter area. If you talk about external iliac vein, usually it's 14 millimeter, and common iliac vein continue to open forces the stent acting on the vessel wall. And also, it has to have a resistance for contracting. And also, she has to have a resistance for compression resistance. So the stent has to have chronic outflow force, radial resistant force and compression resistant force to get an ideal stent. And usually nitinol has this characteristic. The reason why nitinol is more common than steel in the venous system. And it has the ability to resist vessel recoil and withstand compression and external forces, which is the main key design in the nitinol stent in the venous system. Flexibility is very important, again, because venous system is very tortuous, and not all stent design can accommodate this tortuosity. The reason why the flexibility of the stent is different from the company to different companies. The reason why it's very important when you use your stent to look at the flexibility of this stent and use the right stent for the right anatomy. But in general, venous stent requires sufficient flexibility to avoid kinking or excessive vessel straightening at physiological pain, especially under the inguinal ligament. Like you can see here, multiple company, and you see when you bend the stent, you see how the kink is different. Some of them are resistant to kink, and some of them are very, very bad with tortuosity and kinking. I think durability is very important. Venous stent must be durable enough to withstand the repeating bending, lateral and axial compression and torsion to avoid fracture. And venous stent design are variable and not equivalent in their durability to withstand this compression. So every company also they have different durability for the stent. So when you choose your stent from each company, you have to look for durability and flexibility, which are completely different from company to company. Accurate venous deployment also is very important. Also, each company has different deployment accuracy, so you have to look at the accuracy. In general, like a wall stent or a braided stent are known to shorten during deployment, which makes the stent position is very less precise and it's very difficult. Or if you look at like nitinol stent, like every stent, they are designed to expand with a minimum forcing, so you can have very nice, precise deployment. So let's go to a couple questions to this session. Which anatomical location endures the most intense bending during walking and sitting? Usually the inguinal ligament, it has the most intense bending during walking. So the answer will be B. Venous stent design are standard with equivalent durability to withstand the compression and torsional forces. This is wrong, because I said each company has different, or each stent has different durability and flexibility from other stents. So this is false. We go to our third part of our presentation, which is the venous stent versus arterial stent. How is venous stent different from the arterial stent? So let's ask some questions. Arterial are tortuous where veins are muscular and straight. This is wrong. We said the venous are more tortuous than the arterial. All of the following implications are associated with the venous stent design except radial resistant force and compressive resistance. Yes, this is what we need in the venous stent. It has to be a radial resistant force and compressive resistance. High strength and rigidity in the pelvic region. No, we want to be flexible. This is wrong. This is the answer. Long-term durability, yes, because we use it in young people, and potential need for large cell design to mitigate clot formation at the potential venous confluence. This is correct. So the answer will be B. Now we move to the third part of my presentation with the stent structure and design element. If you look at the stent structure and design element, it's very unique. The stent design contributes to the stent performance. A stent design includes rings, you can see it there, elements joined together in the distinctive pattern, special way, and the ring and element provide a radial strength, while the connection play a major role in the stent flexibility and kink resistance. So you have two components. You have the connectors and you have the rings. The more connector, make it more flexible. The more rings, then you have more rigid and resistant to the compression stent. So you need to balance between these two. So what are open cell and closed cell geometry? You hear about open and closed cell. Let's talk about the open cell design. Open cell design are those where the adjacent element have periodic connection, very small connection because more rigid. The open cell, they have more connections, peak to peak connection, they have peak to valley connection, and mid slot to mid slot connection. Whereas the closed cell design are those who are where the adjuvant element are fully connected at each crown, and braided stent may be considered a closed cell design. So usually when you heard about braided stent, it's mostly a closed design. The second thing is that if you look, when you curve the stent, if you look at the inner part of the stent, the blue one, you see how it's compressed, whereas the outer one is being stretched. This is when you have an open cell design. When you have a closed cell design, you see not major change in the cell of the stent when you bend it. So what does that mean? Stent with open cell have the advantage of flexibility, very flexible, but don't cover the vascular wall as uniform as the other design. Because as you see in the inner part, the stent becomes small. They don't cover as the outer part, which is large. Where if you look at the closed cell design, the stent with a closed cell are generally less flexible, but the open cell stent maintain uniform coverage. So it doesn't matter in the inner or outer, the stent will cover the same areas, no change, because they don't change in the size when you bend the device or the stent. The other thing is that in the open cell device, open cell stent, typically designed to not foreshorten significantly during deployment or expanding. So the open cell, they don't shorten, they stay the same. This is very advantage. Whereas a closed cell design usually provide more uniform surface coverage, as we said before, but they potentially lack a desirable amount of flexibility and suffer significant shortage. To summarize that, again, the open cell, it has less uniform surface coverage, but it's more flexible and less shortened. Whereas a closed cell design, it gives you a uniform surface coverage, so more coverage, but the price you pay for that, you have less flexibility and you have more shortening. So you have to be careful. The connection is very important. This is the one which gives you the flexibility of the device. So with regarding to the venous stent, it's important to maintain the balance between flexibility and strength. Venous stent should have enough connector to prevent kink, but not so many to lose flexibility. So the more you have the connectors, you have more flexibility, but you have a less resistant to the compression or less strength. So you have to balance between this strength and flexibility. Again, the fewer connector may make the stent more flexible, but more connector may provide more strength. So you have to look what I'm looking for. I'm looking for strength or more flexibility when I put my stent. So this way I decide, should I use a stent with more connector or with less connectors? The material also is very important. What material are we going to use? Are we using steel or nitinol? And when we pick up your stent, what's the difference? In steel, it's usually moderately flexible, but it has an excellent compression resistance and kink resistant. But what's the disadvantage? It shortens when implanted because the closed cell and does not maintain consistent strength at the end. Whereas the nitinol is more flexible, so it can adapt the vessel of varying caliber than a braided stent. So if you have to put it from 14 or 16 to 12, it can accommodate the different in the diameter of the vein. Greater resistant force than a braided steel, and has a predictable length, so does not shorten. So what is the disadvantage of the nitinol? Slightly less compression resistant than braided stent, and does not have demonstrated durability in the area of flexion. This is the only two things. But in general, the majority of the stent we use is an nitinol stent. Deployment mechanism. We have either the stent, either could be a balloon expandable or self-expandable. but the most commonly we use is the self-expandable stent to treat the iliac vein compression. Why is that? Because a longer length, the self-expandable, you can have a long one, like 100 or longer, whereas the balloon expandable are usually short. Yeah, and the self-expandable more flexible, whereas the balloon expandable are rigid and less suitability to permanent deformity by external forces. So what that means, when you have a self-expandable stent, you have a force, it can bend, but can come back. It has a memory. Whereas self-expandable stent, when it's compressed, it has no memory, stay compressed. So this is a main difference between the self-expandable and balloon expandable. And again, the majority of the time we use a self-expandable native stent. So let's go with some questions. What are the advantages of self-expandable stent period of iliac vein compression? Choose all applied. Shorter length? No. Self-expandable is longer. Increased flexibility? Yes. Rigid and strings? And the last one is it rigid and strings? No. Usually the balloon expandable is more rigid. Less susceptibility to permanent deformity by external forces? Yes. So the flexible one, it has long, increased flexibility, and less susceptible to the permanent deformity by external forces. Whereas stainless steel is deformed permanently by external forces, is more rigid, and less flexible and shorter. The answer would be B and D. Closed cell stent provide more uniform surface coverage, but potentially lack a desirable amount of flexibility. No, this is wrong. This is the opposite. This is the closed cell. Yes, this is correct. The open cell is the opposite. So closed cell, yes, give us a uniform surface coverage, but less flexible. Whereas the open cell provide less uniform surface, but give us more flexibility. Now we go to the number 5, which the factor may impact the stent selection. There's a couple of questions we need to consider when we decide to choose our stent selection. Can you visualize the stent in the position? It's very important. Can I see the stent? It's very well visualized on the X-ray. Can I handle the tortuosity or the diameter of the changes? You have a big, so is the stent flexible to take the tortuosity, and like nitinol can accommodate the change in diameter when you have large and small vein, or you go like from coronary iliac to the IVC. Does it have the renal compression strengths to stand up the amount of compression? If you look about severe compressions, we may think about stainless steel. Or it covers the entire venous lesions, where the stent is going to be deployed or overlapped. Because overlapping is bad in the venous stenting because it has more venous stenosis. And can the stent be passed safely to the target vessels? And there are 2 questions. What are the lengths and diameter requirement for the disease segment? I'm going to choose the stent for it. What is the location of the lesion and what type of lesion is it? These 2 questions must be considered together along with the recommended size and IFU by the company. But in general, if the venous stent is undersized, the stent may not maintain a position and migrate to the heart. And if you oversize, the patient may end with pain. So it's very important to choose the right size. And for the stent, because again, oversized, the patient end with the pain, undersized may migrate to the heart. So you have to be very careful. So these 2 questions is very important to put in your mind when you choose your stent. Another question, are there delivery restrictions caused by the disease axis pain, cheese size, visitor tortuosity, working room, or distance to the lesion? Can the number of required stent be minimized? Because the less stent number be better, because less overlapping and less problem. Is it in your inventory? Do you have this kind of stent? What inventory you have? The risk of puncture site bleeding increase when the large shear is passed through a diseased common femoral vein. So you have to put back in your mind when you choose the size of the cheese and the stent. The distance to the lesion is important. Then you may have to go from popliteal or even from the tibial vein if you are dealing with the lesion close to the common femoral vein. Cheese size and access site may influence the choice of the stent. And finally, make plan for or consider alternative access site if necessary. Again, if you think you are going to be very close to the deployment area, try to use an distant access site like OPTL vein or even sometimes TBL vein. So let's go to question. What's the other question considered when you're selecting the stenting? The length and the diameter required for the disease segment. This is correct. The maximum number of stents that can be used. No, like I need the minimum number. I want to know. I don't want the maximum number. Because I need to minimize the number of stents I need. So that is why I need to use a long stent to minimize the number of stents. The more stents you put, more overlap, more problems. Delivery restriction posted by the disease access vessel, yes, because it may, change your plan. And of course, the type of the lesion is very important. It's compression, or it's fibrotic, or it's post-thrombotic, so you have to know that. So this would be the answer. If the venous stent is excessively oversized, risks include what's going to happen. Patient end with a pain, so patient pain. If you undersize, then patient may migrate to the heart. Now we come to the final part of my presentation, which is the procedure overview. The procedure requirement, you need two parts. You need a capital investment or equipment, like the duplex ultrasound, serum or cath lab. IVAS is very, very important to determine the extent of the lesion degree of stenosis. I cannot imagine, guys, you do a venous intervention without an IVAS. It's very important to invest in that. Disposable, of course, equipment like high pressure balloon, because we are working the venous system, different from the arterial system, so we need high pressure balloon to break the forces and fibrosis, guide wires, and the sheath. So what the factors that determine the procedure success? Clearance of the preoperative thrombosis. If you have an acute DVT patient, be sure you clean all the clot from the venous system, because the more clot you leave it, then you have to stent it. You have put more stent. The more stent you put, you end with the more trouble. Establish of appropriate venous inflow and outflow is very important. You have to go from healthy to healthy, normal to normal. So you have to have a healthy inflow and outflow. And you need to cover the entire area of stenosis. You cannot leave any lesion. So it should be covered from healthy to healthy or normal to normal spec of the vein. And finally, you need an adequate luminal gain. You have to be sure the stent is completely expanded. And the IVAS can help you a lot with that. So how we do the procedure? First, we get an access, usually popliteal, femoral, or internal jugular vein sometimes, under ultrasound guidance. Secure the puncture site, maintain guidewire placement, deliver the sheaths and therapeutic catheters, and maintain access for venogram of the treatment site. Getting access too close to the intended treatment site can lead to the difficulty with the stent deployment. Second thing, pre-stent deployment. Consider the need for removal acute clot in DVT patients. Very important. Again, if you still have residual clot, give the patient 24 hours more on thrombolysis. Intraprocedural imaging is used to determine the appropriate stent size identified of the disease segment. The reason why the IVAS come very handy. Measure the lumen and vessel reduction secondary to the obstruction. IVAS imaging to assist in determine the degree of stenosis and length of the lesion. It's very important, the IVAS. Don't depend on venogram. Choose the stent size per institution preference. Determine the target vessel size. So you need to use the right size for the right stent for the right vein size. And again, always need to oversize at least 2 millimeters. I use balloon to predict the vessel of at site of the lesion. If you don't know how much the size is, you don't have either, use a balloon. You get an idea what the size of the vein, because you don't want undersize into the embolization to the heart. Venous stent usually performed immediately after venoplasty. Procedure overview, I'll not go through that because it's different from company to company. What step you do, it depends, what stent are you using, self-expandable or balloon expandable. This is an easy steps, but you just have to follow the instruction of which company and which stent you are using for your procedures. And finally, post-procedure deployment, very important to use balloon dilatation. After that, after you put the stent, to optimize the lumen gain. It's very important to get a complete lumen gain. Use imaging to confirm that the stent is fully expanded, especially use an IVUS. We use an IVUS, we should stent completely expand, otherwise it would be thrombosed, and access for patency and in-stent restenosis during follow-up. So what are the risk and side effect of the venous stenting? Venous stenting is considered safe, minimally invasive procedure with serious complication only happening on rare occasion or if you don't do good planning or you pick up the wrong size of the stent. Serious complication could be pulmonary embolism, but even though radius happen, that is why you don't use an IDC filters when we put the stenting, even with the DVT. Hematoma, bleeding, sepsis, stent fracture, stent migration, if you undersize, venous occlusion, restenosis or thrombosis risk, within or outside of the stent segment, whether damage, intimal injury, dissection, perforation, or ruptures. The other general risk for venous stenting, allergy reaction to stent, in-stent restenosis, bruising or bleeding at the access site, pseudoaneurysm, back pain, also be experienced during the process of redilatation and stent placement. The reason why, if we have a long fibrotic vein, we need to balloon and stenting. Usually I do it under general anesthesia because it's very, very painful. And even after a couple of days, you have to give a good painkiller for the patient because they have a lot of pain after they leave the vein and put a stent. But again, don't also oversize stent because this also can give you a chronic pain. So it's very important. But again, even though it's a simple procedure, percutaneous procedure, but many times I do under general anesthesia if I have a long fibrotic vein, because I think this vein will be very, very painful for the patient. The potential complication of venous stent, you have an acute complication which may occur during or immediately after the venous stent replacement, like infection at the access site, occlusion may occlude as a result of venous thrombosis, or as a result of placing a stent that's not fully opposed to the vessel wall or not fully expand, or could happen after venous stent placement. Additional dilatation usually performed to be sure that the stent is completely open for nitinol stent, or ensure for opposition of the stent if you use stainless steel stent. Migration or embolization of the stent, it happens if you undersize the stent. The mortality rate after endovascular vascularization is low, ranging from 0 to 1%. The most common complications are early thrombosis, less than 30 days, and late thrombosis, more than 30 days. That is why you need to be very aggressive with the anticoagulant from the intraoperative and day one, because the most stent thrombosed really very quick within 30 days. This is different from the arterial stent. Chronic complications usually happen over time, recurrent stenosis. If it's okay at the edge of the previous placed stent, you can overlapping stent is placed. Stent damage, if it can be damaged by external forces, repeated motion and bending, compression and twisting can lead to the stent fractures. Some speculated that stent beneath the inguinal ligament or overlapping stent beneath the inguinal ligament may be associated with a stent fracture, but this is nothing, nobody proves that. You can cross the inguinal ligament with a stainless steel stent and reported similar patency and the same as if you put it in suprainguinal segment. So crossing inguinal ligament with the venous stent is not a problem like an arterial system, and it's safe, and nobody showed it increase your restenosis or occlusion rate. The most important is that good inflow to and outflow from the stent segment is very important to maintain patency of successful iliofemoral recanalization. So again, the key is that you have to have inflow and outflow. You have to stent from healthy to healthy to get a good outcome. Because venous system is low pressure system, can thrombose very quickly. If you don't get from healthy to healthy, you end with the early thrombosis. So last question now, what are the procedure requirements? You need a capital requirement, high pressure balloon, sheet, the above, of course. The last thing, I guess, the most accurate imaging modality to evaluate iliofemoral outflow obstruction is the scope. Thank you very much for your attention, and I hope I give you some overview about the principle of venous stent, and I'll try to be live with you guys to answer any question. Thank you very much.
Thank you, Samer. I think you have to stay for a while because I think we have some questions.
Hi, Dr. Ayman. Sorry, I just finished my case, but I'm ready for any question.
Okay, thank you. Professor Adel, go ahead.
Just because all listening, others can use.
Can you hear me, Dr. Samer?
Yeah, I can hear you. Go ahead, please.
Okay, thank you for this very good presentation and review of guidelines. But if you have a young lady, 25 years old, and she has only lower limb edema, this is CAP class 3, and she has non-thrombotic stenosis of iliac vein. Would you go with the stent with complications such as DVT and limb edema also?
Thank you for this question. If I understood right, that she already has symptomatic, right? And she has a venous hypertension. Does she have an ulcer, you said, or just venous claudication?
Only edema.
Only edema.
Yes.
No, I don't think it's worth it because you see, it has to be anticoagulant and risk of thrombosis and DVT. I agree with that, So just edema, no, I will not do it. I try conservative management unless the edema become very massive and interfering with her lifestyle. Then I may consider it. But if just edema, which can be treated conservatively, I think it's the best way to go.
Yes, thank you.
Thank you.
Okay, please. May introduce yourself, Samer?
Dr. Mohammed Magdi from Jodorable Heart Research Institute. Thank you, Dr. Samer, for this nice presentation. But I want to ask, which is the best way to close the lesion used usually? And if you didn't succeed to close the lesion from below, you can close the lesion from above?
Thank you for this question also. I mean, the problem is you cannot have only one wire. You have to have a multiple wires, Of course, depending on what lesion. Are we talking about thrombotic or non-thrombotic occlusion or stenosis? Are we talking about instant stenosis, But I always try with a glide stuff, and then I go to more C2O wires. If you cannot go from below, yes, I go from above. You have to keep trying from above or below, But sometimes you have to be very aggressive, And perforation in the venous system is not a problem. So we need to be aggressive, especially with the wires. But you cannot just have one wire and start your venous practice. You have to have multiple kind of wires, But this is what I will do.
As regard iliofemoral occlusion, okay?
Sorry?
As regard iliofemoral occlusion,
yes.
You prefer to cross over or from the internal jugular vein from above?
You have to be access for both sides, I always try from below, from femoral or popliteal, depend where is the occlusions. And then if it's not, I go from above. But you have to be prepared for both, So I mean, I cannot go just say one side and that's it. If you fail, you should not try. No, you should try both sides. But always I like to start from below and then go from above, because especially if you have a flush occlusion and you have to go from above. So it depends where is the lesion exactly, but you have to be prepared from both sides.
The last question. What do you prefer after stenting, NOAC or Marivan?
Oh, sorry, or what?
Anticoagulation. What type of anticoagulation you prefer?
Yeah, after stenting. There's no, guideline is like a kind of consensus on the anticoagulant. 5 days, and I put them on Clexan. Have to be really aggressive because most thrombosis, the venous happen in the acute stage. Doesn't want even we do ultrasound before patient discharge. So because the time where it's different from the arterial, it's the time where venous thrombose, the stent thrombose. So usually we give anticoagulant very aggressive 5 days first with a Clexan, full therapeutic, and then we start with a NOAC. NOAC usually give it to 3 to 6 months, and after that we move to the antiplatelets. But again, there's no guidelines, and it depends on how is the patient. If the patient is hypercoagulable, then you have to go for life with a NOAC. So it depends, but you have to be very aggressive with anticoagulant, especially at first 3 months.
Thank you very much.
You're welcome.
Thank you, Samir. I have three small questions from the educational point of view. First, there are many venous stents. That means we don't have an ideal stent.
Recording in progress.
I mean, what we use now, mostly we use an artery stent, and we have normal stent also from Bard, and now we're getting an oblique stent to decrease the chance of contralateral DVT when we deal with the May-Turner syndrome. But unfortunately, we don't have an optimal stent. Again, you cannot just have one type of stent because depending on what the lesion you have, and then you have always the balance between flexibility, durability, and the compression.
My next question, when general anesthesia is mandatory during venous stenting?
This is a good question. I mean, if I'm dealing with chronic occlusions, or not DVTs or acute thrombosis and May-Turner like stenosis, if you have dealing with a chronic occlusion, especially with the external and common iliac artery, I mean, it's very simple. It's local anesthesia, but ballooning is very, very painful, especially with a chronic occlusion. And local anesthetic will not work. So these cases, I will do under general anesthesia. But if it's just a stenosis or May-Turner syndrome, I do under local. But if it's long occlusions or IVC occlusions, which need a lot of ballooning, I expect a lot of fibrosis, it is very, very painful. So really has to be done under general anesthesia.
I would like to ask, in arterial stent, we never cross a joint. In venous stent, is it permissible to cross the joint? And what about the fracture rate for such stents?
That's a good question also. Yes, you can do that. And the study showed it's no different really. If you cross or not cross it, the fracture rate is the same, especially when you use retinol stent. But the most important really in the venous, it has to go from healthy to healthy. So don't hesitate to cross the inguinal ligament if you're going to get to healthy inflow. Because remember, the venous system different from the arterial, the inflow from below, not outflow from above. So your inflow is a profunda or common femoral vein or our superficial femoral vein. So if you have a disease in the common femoral vein, you cannot leave it. Because again, it's the low flow system. There will be thrombose. I mean, if you don't have an optimal result, things will be thrombosed. So you cannot compromise in the venous system. We can compromise in the arterial. You can leave mild stenosis, moderate stenosis. In the venous, it has really to be, looks perfect. So you have to go from very healthy. So even if you have to go all the way to the profunda vein with a stent, you have to do that. If you have a stenosis before the stent, you don't address it, or you don't cross the inguinal because you're afraid of the compression, then the stent will clot it. So again, don't worry about inguinal ligament. You can cross it safely. The fracture rate is really very low, but the most important to get to the healthy. So if you have any doubt that disease in the common femoral vein, cross the inguinal ligament and go and put the stent all the way to the profunda or common femoral vein.
My last question, in May-Turner syndrome, sometimes we jeopardize the flow of the other limb. How can you perfectly overcome this?
I mean, this is a major issue, really. And I just had a patient really who came last, 2 weeks ago, because of what happened a couple of years ago. I sent her, and you have to cross, you see, to the IVC, because if you're treating May-Turner syndrome, the stent has to go to IVC, because otherwise you skip the compression. And she was doing fine. Then we switched her to antiplatelet after 1 year. And then after 2 years, she came with a DVT on the other side. So they are thrombolized the other side and they put a kissing stent. But it's not advisable to use a kissing stent from the beginning. I think try to pull as much as, not to like completely protrude the stent to the IVC. And now we start using the oblique stent, which is, I think, that advantage. You don't put too many stent or strass in the IVC. But this is a concern. But again, try to minimize how much you put a stent in the IVC, but also don't miss your lesion. The reason why IVAS is very important in this situation.
Thank you, Samir. Thank you, Samir. We all enjoyed your lecture and your interaction. I hope we will meet very soon in person and get a lot of your experience.
Thank you very much. Thank you, Ayman, very much. And really, I'm sorry I was unable to come, but I'm just in surgery. I just finished now. So thank you, guys, and hopefully we'll see you soon. Thank you.
From Eurocenter Vena Lympha. From Eurocenter Vena Lympha. I would like to welcome the giant. When we are talking about tips and the tricks of sclerotherapy, we all mean Attilio Cafezzi. Professor Attilio now is going to discuss tips and tricks in sclerotherapy. The mic is yours, sir.
Thank you. I sincerely thank my friend Ayman Fakri and all the friends from the Egyptian Venus Forum. So my topic today is to speak about how to improve our outcomes in sclerotherapy. So during my presentation, I will try to give some tips and tricks, but also to provide some scientific data to advance our clinical practice, let's say. This is my disclosure slide. Okay, whenever we treat varicose veins, we know that we need a good diagnosis. And this is the very first important, let's say, trick to avoid complications and to get proper treatment. That's why a long time ago, we provided a few documents such as this one and this one concerning the best way to approach our patients with the varicose veins through duplex investigation. Why? Just for example, we need to know exactly how is the situation of the saphenofemoral junction in case of varices related to the incompetence of the great saphenous vein or the saphenopopliteal junction for the small saphenous vein. So why? Because there are many patients who exhibit reflux in the great saphenous vein, but in fact there is no reflux at the terminal valve, which means that probably the patient has a lower hydrodynamic column, and that's why our sclerotherapy could be somehow more effective. So the hemodynamic and morphologic condition of the terminal valve, which you can see here, and of the pre-terminal valve, which you can see here, is something we should know before approaching the patient. Furthermore, we know that only a very little part of our patients exhibit a complete reflux from the groin to the ankle in the great saphenous vein. Again, we should target the proper vein for the proper treatment. And so the majority of the patient, for example, may exhibit a reflux down to the knee, and that's why this is the segment to be ablated by sclerotherapy, for example. One more issue is the anterior accessory saphenous vein, which is a kind of ghost in literature, because there is very, very little report about the anterior accessory saphenous vein, which on the contrary is responsible for varicose veins in about 10 to 15% of our patients. So the anterior accessory saphenous vein is in another location, a little bit more lateral to the great saphenous vein. And again, this is a proper diagnosis to be planned. The small saphenous vein is even more complicated. We know about that. That's why proper duplex investigation will help to improve the treatment. What about the perforators? The perforators, that would be a very long story to discuss. What we know is that in primary varicose veins, the majority of these lower leg perforators are re-entry perforators. So probably we could avoid to treat these perforators at first instance. And then we should wait after ablating the saphenous vein, the tributaries, we should wait and see what happens. And the majority of these perforators would return competent. Concerning recurrent varicose veins, we should investigate very carefully where the reflux comes from. Because everybody knows that we have patients, for example, with refluxes all around the leg, but the real let's say, source of the refluxes is in the pelvic area or in the lymph node vein network around the inguinal area. So to make it short, these are perfect cases for sclerotherapy, for example. On the contrary, there may be patients who exhibit a recurrent varicose veins related to the anterior accessory saphenous vein or to, anyway, a reflux in a persistent saphenofemoral junction because of a malpractice, of a different strategy, or progression of the disease. So at the end of the day, what we need is a proper mapping. Once you have a good diagnosis, then you have a good treatment. This is the very first message to take home, a proper mapping prior to our sclerotherapy. When we do this, reticular varices and telangiectasias, things become more complicated because we really don't telangiectasias here and some reticular varices above and below. So a classical upside down tree is very easy to understand that we should anyway treat this vein because the reflux comes down, as you can see in this classical example. But there are patients where the reflux does not come down, but probably goes up. Or anyway, we have a lot of telangiectasias draining into a reticular varicose vein. So what to do? That's the issue. Probably we could start from the telangiectasia and wait and see what happens to the reticular varices draining in a perforator here, or with an incompetent perforator. Even more complicated when we have this situation, for example, with telangiectasia above and below a reticular vein, reticular varices. So this is an issue for our sclerotherapy. That's why probably to work, let's say, in a smooth manner could help. And then, of course, we have telangiectasias and reticular varices related to a kind of hidden great saphenous vein incompetence or small saphenous vein incompetence. This patient came to me and told me, "Doctor, please inject my telangiectasia. I want my leg clean." I investigated the patient and I found an 8 millimeter small saphenous vein refluxing. So I told her, "I cannot treat your telangiectasias. I'm sorry. I need to treat your saphenous vein." She was disappointed. She went away, came back to me with a lot of pigmentation because she got sclerotherapy of telangiectasia without treating the saphenous vein. And that's a major mistake, let's say. So how should we treat our patient with sclerotherapy? Raymond Tounet was one of the fathers of sclerotherapy. Let's say from above downwards and from larger to smaller veins. These are two basic rules with some alternatives. So when we speak about minor varicosities, reticular varices and telangiectasias, we mostly use and should use liquid drug. So we should start from larger to smaller, from upper to lower refluxes. Whenever we inject the reticular varices, we should aspirate blood before injecting. That means we are into the vein. This is not possible with the telangiectasia. Then we should always use air block because injecting some air into the vein prior to liquid entrance, that means that we clear the vein. We improve the outcome because the lower the blood, the better the outcome. And then again, minor concentration, minor doses, which means, for example, 0.1, 0.2 milliliter for telangiectasia and 0.5 or 1 milliliter for reticular varices. So overall, I would say multiple injections and low doses at low concentration. This is a kind of basic rule when we deal with minor varicosities. We have different drugs, which we can use at least in Europe, and we will see very briefly. For example, polidocanol, we could start from 0.25 even to 1% in liquid form. This is a medium sclerosant power. It is transparent fluid, very easy to manage, and the extravasation risk creating necrosis is not so high. Let's say that the pigmentation could be a little bit an issue. Then we have sodium tetradecyl sulfate, which is not probably the most used one for minor varicosities. We are talking about minor varicosities now. 0.1, 0.2%. It is stronger than polidocanol. That's why you should take care of your necrosis risk, for example, and you may get some allergies. It's not so powerful when you extravasate, so you should combine it, for example, with the sodium salicylate to get some pain when you extravasate. Another possible drug is chromated glycerin, which mostly is used diluted with water or with mepivacaine because it is quite viscous and it is very safe because it's very weak. So you should use it, let's say, for little telangiectasias and so on, but it is painful when it is extravasated. And then sodium salicylate, which is so old and so good, let's say. It is probably the oldest of all the sclerosant drugs for the minor varicosities. Anyway, it has a low sclerosant power. It is transparent, very easy to manage. Of course, you can get allergy only if the patient is allergic to some acetyl salicylic acid. And the pigmentation rate is the lowest among all these sclerosant drugs. Material, what should we use to inject our patient? Of course, needles. For minor varicosities, I would recommend 30 gauge needles or 27 gauge needles. And then the classical material that you can read. Let's say syringes. I wouldn't use 1 milliliter syringe because you inject with too much pressure through the piston and then you get more easily extravasation or whatever. So 2.5 or 5 milliliter syringe would be better. I'm used to apply some creams after the injection, some venotropic anti-inflammatory creams on the treated areas. And my patient usually get some food supplements or drugs in selective cases such as heparin or whatever. Then now we come to foam. Foam has been discovered, let's say, around 80 years ago, but was somehow resuscitated, let's say, by Lorenzo Tessari, before Lorenzo Tessari by Cabrera, Monfreux, and others. But anyway, the real diffusion of foam is due to Lorenzo Tessari's invention of the three-way valve technique. Unfortunately, it is not so good for minor varicosities. These are two slides where we clearly see that we can get some necrosis with foam if it is too high the concentration. So for minor varicosities, still, I would advise to use liquid drugs. Okay, we may have some cases such as this one or this one, a kind of matting, where foam sclerotherapy may have a role. But generally speaking, I would prefer for telangiectasias and reticular varices liquid sclerotherapy. So you can use foam, as you can see here, for example, through proper needle. In case you use foam, probably 27 gauge needle is better than 30 gauge because otherwise you disrupt the bubble and the foam converts into liquid. So which are the volumes per injection? So per injection when we use liquid sclerotherapy. This is a kind of consensus which was published in 2013. As you see, for telangiectasia, up to 0.2, for reticular veins, up to 0.5, and for varicose veins, direct injection, for example, up to 2 milliliter, liquid sclerotherapy. When we, on the contrary, speak about concentrations, here it is really difficult. Let's say that some tips and tricks, okay? Whenever you inject telangiectasia, you should use low concentration because 0.25 polidocanol or 0.1% STS could be enough. If it's not enough, you can increase. For varicose veins, you can use a double concentration, for example, 0.5 polidocanol or 0.2, 0.3, 0.5% STS. When we talk about varicose tributaries, then we start to use 1% polydocanol, 0.5 or 1% STS. When we talk about larger veins, for example, saphenous veins, small saphenous vein, great saphenous vein, anterior accessory saphenous vein, or venous malformation or recurrence at the groin or at the popliteal area, then I would recommend to use in the majority of the cases 3%, because this is the escape point, this is the major source of reflux, let's say. So you should never, let's say, use the standing position to inject the patient. I would largely prefer the supine position, and you should control the perfect position of the needle and try to understand immediately if you are extravasating, because you should get some pain, you should see some bubble. If you inject air, I mean, if you use air block, then you would extravasate air, which is a safety measure. You should, well, this is a great debate, but you could or should, I don't know, use compression. There is some debate, as we will see, but overall, compression by stockings especially is helpful to decrease side effects. You can use eccentric compression through rolls, through latex, through pads. And the duration of compression may depend on the kind of veins that we treat. For example, a lower duration for telangiectasians and higher duration for varicose tributaries and saphenous veins. And normal walking is encouraged in these patients after the treatment. Of course, on the contrary, sauna or exposure to sunlight is not suggested immediately after sclerotherapy for the risk of pigmentation. One thing we may do before puncturing the vein is to elevate the limb. That would result in a reduction of the diameter of the vein which we have to treat. Of course, the smaller the vein, the higher the difficulty to catch the vein. We know that. But the smaller the vein, the lower the blood amount, which is very interesting. That's why somehow we also use compression in sclerotherapy. For example, what we do with compression is to try to optimize the result, because we reduce blood in the treated vein after the treatment. We can so improve fibrosis. We know that sclerotherapy results in sclerothrombus. This is the final result. If you have more blood, you have more thrombus. If you have less blood, you have more sclero, you have more fibrosis. That's why the reduction of blood into the vein before and after sclerotherapy is a major key point in sclerotherapy. Anyway, what we know from literature, let's say for sure, is that you reduce side effects through compression, pigmentation, inflammation, hematoma, clot retention, and so on and so on. So compression overall is probably the best way to, together with the proper technique and strategy, the best way to reduce side effects in sclerotherapy. For example, eccentric compression. This is an elegant demonstration from Ugo Parch that through eccentric compression like this, or let's say normal latex pads and so on, you can achieve the occlusion even of the saphenous vein, which is so difficult, especially at the thigh region. And that's, for an example from Ugo Parch, how stockings plus pad can significantly reduce the diameter of the great saphenous vein. So the importance of the eccentric compression and of pads during sclerotherapy. Unfortunately, compressing telangiectasias is impossible to compress telangiectasia. Even 100 millimeter of mercury, always our giant and master Ugo Parch showed through these elegant pictures, you cannot compress telangiectasia because they are dermal varices and you cannot compress the dermis. So the only way to compress is through let's say plasters in a tangential way. This is the only way to make your telangiectasia disappear, to reduce the blood inside the telangiectasia, not perpendicular, but tangential. Let's say that the combination of compression and immobilization is important in foam sclerotherapy, because compression should be somehow delayed a little bit when you use foam. And anyway, the patient should be immobile for a few minutes after foam sclerotherapy. That would reduce the dislocation of foam significantly. If you immediately compress, or if the patient immediately moves, your foam will move and the result will be lower. So let's go to foam sclerotherapy. This is the second part of my presentation. Let's say that the smaller the bubbles, the better the foam, the better the outcome. So one main goal is to achieve a small bubble foam. This is very important. Which are the variables which condition our formation?